of the reproductive system. And basically, the reproductive system is regulated by the neuroendocrine system. Typically, now why is that not opening? Open. There we go. Okay, that includes the hypothalamus and then the pituitary as well as the gonads. The gonads are the sexual organs in the male and female, and the primary gonads obviously in the female are the ovaries, and in the male it is the testes. And what they do is they secrete hormones that will produce the ova as well as the sperm. And then it goes through the process of readying the body either for menstruation, pregnancy, and or fertilization. So basically the system then regulates ovulation, it regulates spermatogenesis, which is actually the production of sperm, fertilization, when the sperm fertilizes, catches the egg, and then the development also of secondary sex characteristics. And those become important when we're doing some evaluation of some problems that are associated with the reproductive system. The function of the testes, again, to form sperm is done in the seminiferous tubules. And in addition then, hormones are secreted. And the accessory glands of the male reproductive system include the seminal vesicles, the prostate gland, as well as the Cowper's gland. And what they do is secrete fluid that actually together becomes part of that fluid, or the ejaculate, that actually protects the sperm and allows the sperm to get to the ovum in order to fertilize it. The function of the ovaries then is to produce eggs, also to complete ovulation, and that is done according to hormones as well, and then to secrete hormones, and then to develop secondary sex characteristics, which is also the case for males. So there are some hormones that you should be familiar with that are produced by both the ovaries and the testes. FSH, or follicle stimulating hormone, actually stimulates the ovarian follicles in women, and it also stimulates the seminiferous tubules in men to produce sperm. So in females it's the egg, and in males it's the sperm. Luteinizing hormone, or LH, completes follicle maturation in the female, and then stimulates the ovum to actually be expelled into the fallopian tube. And it also triggers then, with that release, the production of progesterone. And in men, luteinizing hormone triggers testosterone production. Prolactin actually stimulates the mammary glands in the woman in order to prepare the breasts for breastfeeding. They really don't know what prolactin does in males. Estrogen really affects the secondary sex characteristics, and it is in females, it's very active in producing uterine changes, and also it's important in the menstrual cycle. Again, in men, we're unclear what estrogen does, but remember that men also do have estrogen. They have all the same hormones as women in differing amounts and for differing purposes. Progesterone will help them maintain an implanted egg once it has been fertilized. Testosterone is responsible for male secondary characteristics, as well as sperm production. And women then also have small amounts of testosterone. Some women have more than others and actually can develop some male secondary characteristics such as hirsutism, and increase in the amount of body hair. The circulating amounts of hormones then are controlled primarily by a negative feedback system. And in your book it does have some figures that you can look at that. But sometimes also there is a positive feedback involved, but primarily negative feedback. The female reproductive system, we have some definitions you should be familiar with. Menarche is actually the very first menses, and it's actually a sign of puberty in women. Usually it occurs around 12 to 13 years of age. However, we are now seeing that it can sometimes start before the age of 10. They are thinking that it is related to obesity and increased weight, although there is not a lot of evidence to that, but as we get larger, menses are beginning sooner. The menstrual cycle, usually the first few months, even to a year, is a little irregular. In other words, it doesn't come on a regular basis. You might have one month and then skip the next, etc. Eventually, it does reach a fairly normal cycle. However, that's highly variable amongst women, average being about 28 days. Usually it lasts about 4 to 6 days, with the heaviest flow occurring on the first 1 to 2 days. The menstrual cycle occurs whenever there is ova released and it is not fertilized, because then estrogen takes over. Progesterone is not produced as much, because remember, progesterone actually prepares the woman's body to take care of that implanted fetus or implanted embryo. And then changes occur with the menstrual cycle with regard to levels of hormones. So when someone has abnormal menses, it could be related to abnormal levels of hormones. Then we also see then endometrial changes that occur during that menstrual cycle. Menopause is considered the cessation or ending of menses. It is associated with a decrease in ovarian function, and it's usually considered complete after a woman has not had her menses for about a year. We call that amenorrhea, where you don't have menses. When we talk about the sexual response in men and women, essentially there is quite a complex play between the psychological and physiological events that occur with sexual intercourse, but in reality, the response changes are quite similar in men and women. You just have different organs that are being affected. Age can also occur and affect the reproductive system, and that's primarily related to decreases or actually increases in size. With women, they get increasingly pendulous breasts, but these can impact their abilities as well as their pleasures. And also there is increased chance for health abnormalities as we age, such as infection. As we lose flexibility and tone in our muscles, we can develop prolapse and other problems such as that. One of the first things we want to do when we are evaluating men or women for problems associated with the reproductive system is to do an H&P. You should know that women who are on oral contraceptives, and particularly women who take combination oral contraceptives, in other words, estrogen with progesterone, should not take that if they have a history of hypertension. Evidence has shown us that women who are hypertensive and take oral contraceptives, particularly combination, have an increased risk for blood clots, cardiovascular disease, and stroke. Way back when, in the early 50s, 60s, my 39-year-old aunt started taking oral contraceptives when they initially came out, but she was hypertensive and she did die of a stroke at 39. So that has been kind of right there in the top of my head ever since. Very young and dynamic, and that's what they attributed her death to. In addition, people who have cholecystitis, hepatitis, and COPD really should not take oral contraceptives either. Women who have, when you're doing the H&P, if you discover that a woman has had multiple sex partners, you should know that they are at increased risk for STDs. So it's important that you teach her the importance of doing annual chlamydial testing, and that's primarily based on her history that she's given you, multiple sex partners. When you're doing an evaluation and diagnostics, there are a number of diagnostics we look at in the urinary or in the reproductive system. Urine studies are one, and probably the most important is pregnancy testing, or human chorionic gonadotropin, HCG. Also, we can do hormone studies on estrogen. Blood studies can be done to check not only hormones, but also tumor markers. Tumor markers that are important in the reproductive system are AFP, alpha-fetoprotein. Also, cancer 125 is a tumor marker that is significant, and PSA, the prostate screening antigen. Also important in the reproductive system is checking for syphilis, VDRL. Also they can do an RPR, which is a reagent. If VDRL and an RPR are positive, usually what they will want to do then is an FTA-ABS to positively diagnose syphilis. A person who has had syphilis will always be positive for VDRL. So what you want to check for is active syphilis. So you would go on and do that further testing. Cultures and smears are also important. Again, remember, if a woman reports multiple sex partners, you would want to do annual chlamydial testing, and that's annual. That's not just a one-time thing. Cytology testing, testing cells, also radiology tests. Probably mammogram is right now at the height of the controversy. There are some discussion as to when one should start mammograms, and insurance is going to play a role in that, I'm sure. Remember that also you can do ultrasounds and MRIs, but anytime you do an x-ray on a woman, particularly an abdominal x-ray, you want to check, especially if she is of childbearing age, that you check to make sure she's not pregnant before you do abdominal x-rays, because you don't want to expose the fetus to radiation. Invasive procedures can also be diagnostic, such as breast biopsies. We can do laparoscopies and D&Cs. Also a colposcopy, which is a direct visualization of the cervix. Is used particularly if a woman has had an abnormal pap smear, and also if she has had exposure to DES, diacetylbestrol. We don't see that anymore so much, but we do still see that in the third world countries. I was exposed to DES, and so was at increased risk for cervical cancer secondary to that. My brother was a DES, had DES exposure. He did die of lung cancer, although that then was related to Agent Orange exposure as well, which also increased or caused a fourth-chamber cardiomyopathy. So whether or not DES played a role in his development of cancer, we don't know, but he was exposed, so he had increased risk for like testicular cancer and other types of reproductive cancers. Then in chapter 52, here we were looking at an overview of breast disorders, including breast cancer. There is a PowerPoint on breast cancer. I just incorporated into this overview. Screening guidelines, here again is where that controversy lies. It was that women should start getting annual mammograms at the age of 40, as long as you are in good health. Obviously, if you have a history that would suggest earlier mammograms, particularly if you had a mother or a first-degree relative who had bilateral breast cancer, that you would want to have more frequent and earlier mammograms. Also, if you are positive for a BRCA gene, what's her name? Brad Pitt's wife, Angelina Jolie, had bilateral mastectomy because she was positive for BRCA genes. And it eliminates the possibility then of breast cancer when you have those removed. New guidelines for mammograms is a woman who has a normal risk should actually begin at annual mammograms at around the age of 50 and then continue through about 75 years. Now, that's up to conjecture, it's up to individual physicians. Hopefully, they don't have this question on your boards because really they haven't made a determination one way or the other. So read it carefully if there is one. Now, breast self-exams are an important part, although even that is now being lessened as an important part of evaluation. One of the newer techniques, there have been changes in that. It used to be that you could either check your breasts circularly or up and down. Now the recommendation is just up and down. The finding is that you usually will find lumps in the upper axillary region. So that is an area where you do want to do breast self-exams. The value of breast self-exams is that you become familiar with what your own anatomy feels like, and so you can then be familiar when changes occur. I remember one time I did have fibrocystic breast disease, and so I never knew. You get lumps and you don't know what they are. I remember calling over to the clinic at the time I was with Essentia, and I said, I found a breast lump and I need to see somebody. And they said, oh, we refer all lumps to the surgery department. So I was now classified as a lump. And I had never seen, I went in and I saw the physician, and when he checked me, he checked my unaffected breast first, and I was gonna say, oh no, that's not the breast. But that they checked them both, obviously. Never saw this doctor before, and I think for the next 3 weeks running, every time I was in the hospital, who did I run into but the guy who checked my lumps? You know, and then like when he had checked my breast, I went to get up, and he kind of pushed me back down, and he said, oh, here we have to check further under the axillary. So it was an embarrassing situation for me, and then I see him every day after that. It was like, ah! So that actually can be a reason that women don't want to go for, you know, checking for breast lumps. And, you know, it's unfortunate because, you know, early detection is usually results in cure. So that can be very difficult. So, for women who have regular menses, the most comfortable time to do breast self-exams is actually right after menses. There's less lumps and they're less tender at that point in time. If menses are irregular, or if a woman is postmenopausal, then you should suggest to her that she should choose the same day each month and do it on that day. Also, if women are taking oral contraceptives, they generally can do the breast self-exam on the first day of a new package, and that gives some pattern and rhythm to when you are doing the self-exam. So assessment and diagnostics of breast disorders, obviously mammogram allows us to visualize the breast's internal structure. It uses x-rays, and it can detect lumps that cannot yet be felt. Mammograms these days are even three-dimensional, so they can be very good. Ultrasound can also be used, as can MRIs. MRIs are oftentimes done if a mammogram or an ultrasound looks suspicious. Also, ultrasounds or MRIs are done for high-risk women. For example, women who have a first-degree family member who had breast cancer. Biopsies are the way that we can get a definitive diagnosis. That's the only way. We can do a variety of types of biopsies. Probably the most common is a fine needle aspiration. And the benefit of doing FNA is that you can get the results fairly rapidly in 1 to 2 days, sometimes 1 to 3 days, whatever. Also, we can do core biopsies, we can do vacuum-assisted biopsies, and then also surgical biopsies in the OR. That would allow us to get do frozen specimens even while the patient is still in the OR. Now, benign breast disorders, which are just that, they're benign. Mastalgia is basically, algia is breast pain. It can be related to the menstrual cycle or maybe not. My mother had mastalgia her entire adult life, and it was not related to a cycle. Typically what the physicians will tell you is take less caffeine. They do encourage you to take vitamins E, A, and B, also primrose oil, using a good support bra. Also, you can use compresses, ice, analgesia, usually just mild analgesia, sometimes anti-inflammatories. Also, oral contraceptives can be ordered to deal with the pain. A common drug used for mastalgia is danazol or Danacrin. One of the problems with that, though, is that it can cause acne, edema, and hirsutism, that increase in body hair. Breast infections are also sort of considered benign because they're not malignant. We already talked about mastitis as being an inflammatory condition or inflammation of the breast, primarily of lactating women, those who are breastfeeding. Signs of infection, as we discussed before, are localized areas of warmth. It might be red or pink and very tender to the touch. And it is caused by Staph aureus usually. Treatment is with antibiotics. It's quite easily treated, and actually when the woman is breastfeeding, she can continue to breastfeed even during the time that she is getting taking the antibiotics. One of the problems with mastitis, lactational mastitis, is it can turn into an abscess. If the woman has been on antibiotics for a few days and that mastitis is persisting and the skin becomes quite red, edematous, she can actually feel a mass and she develops a significant fever, that usually has to be irrigated and debrided. But even then, with an abscess, she can continue to breastfeed if she can tolerate the discomfort. A lot of times what women will do is they'll just pump their breasts and then the baby will still get breast milk, but she's not actually feeding from the breast. Fibrocystic changes then are considered benign. These are changes in the breast tissue. Usually it's hyperplasia or overgrowth in the epithelial lining. Cysts can form, and that's primarily due to an increased sensitivity or response to estrogen and progesterone. Fibrocystic disease can be painful, and the reason for that is as the cysts grow, it puts pressure on the nerves, and so that can cause pain. It primarily affects women between 35 and 50. It can, again, be cyclical, accompany the menstrual cycle. And the reason we think it might be related to that is because most women with fibrocystic disease, once they go into menopause, don't have problems with fibrocystic problems anymore. There can be nipple discharge, milky yellow, even to green, and they may actually feel lumps in the upper outer quadrant, which is what my experience was with fibrocystic disease. Treatment is aspiration or surgical removal with excision if it becomes so painful. If it is recurrent, you should again check to see that it is with the menstrual cycle. Make sure that you are going for follow-ups because there's always the chance that it might not be fibrocystic. But fibrocystic disease has not been related to cancer, so that's a good thing. It has not normally been associated. Fibroadenoma is a common cause of discrete benign breast lumps, typically affects women 15 to 40. They usually what you get are small painless lumps. They're well delineated, they're round, they are mobile, they are quite firm and sometimes can feel a little rubbery. It usually does not cause retraction or discharge from the nipple. Definitive diagnosis of fibroadenoma again has to be done with biopsy, typically fine needle. And treatment oftentimes is with cryoablation, cold laser, and then again regular monitoring. Fibroadenoma can become malignant if it has additional cellular changes. Nipple discharge can occur for women that is benign. It can be spontaneous or it can just occur with manipulation. Galactorrhea is what we call an inappropriate milky lactation. Galactorrhea can occur in relation to certain drugs a woman is on, endocrine problems, or even with neural problems. Discharge can, however, also be associated with cancer, with papillomas, ductal ectasia, but the majority of discharge is really non-malignant. Intraductal papilloma usually is a benign wart-like growth in the mammary ducts. That can cause bloody discharge. Usually it can be found under the areola, usually affects women 40 to 60, and treatment is excision. Ductal ectasia, also benign, particularly in and around the menopausal area. It involves the ducts, and it can cause sort of a multicolor sticky discharge. Initially it is painless, but it can start to burn, become quite itchy, can cause inflammation, and then eventually retraction. Later signs of ductal ectasia are bloody discharge, and usually it's treated with warm compresses. They also give antibiotics and bring them back in for follow-up and surgical excision if necessary. Gynecomastia particularly affects males. It is transient inflammatory enlargement. A lot of times it affects adolescents. It is temporary and benign. It is not a risk factor for cancer. Basically, it's thought to be related to an abnormal amount of androgen or testosterone in relation to estrogen. Remember that males have both testosterone and estrogen, and what happens is they may have a little bit more estrogen than what the normal ratio calls for. However, it can be related to other diseases such as drugs, hormones, also digitalis, INH are a couple of drugs, ranitidine, which a lot of men are on, spironolactone, and also drug abusers on heroin, marijuana also can develop gynecomastia. Senescent gynecomastia, or with aging, is primarily due to an increase in estrogen. Initially it starts on one breast and then goes to both. Treatment is, again, biopsy. You cannot rule out that they don't have breast cancer. Occasionally men do. With hyperplasia, if it's just an overgrowth of tissue, they wouldn't do any treatment. Usually it's self-limiting, and it will go away within 6 to 12 months. With regard then to changes in the breasts, with aging, there is loss of fat and support. Again, women particularly become more pendulous, so using a good support bra is important. The mammary glands and the glandular tissue will atrophy and lessen. And so that's kind of a good thing as we age, because then it's easier to feel masses. Intertrigo, or dermatitis that is caused by friction, is more frequent in the older woman, as is a woman going to get a mastopexy, which is a surgical lift of sagging breasts. Again, it is very important in the elderly that we encourage PSEs, breast self-exams, as well as annual self-exams. Also, the recommendation is to have a clinical examiner check, either a physician or a trained nurse practitioner, check the breasts every 3 years. And then you should instruct the elderly to have all breast masses or lumps checked out and followed up and evaluated. Breast cancer then, typically we see an increase in breast cancer in women and men over the age of 60, particularly women though. Risk factors are aging over 60, family history or personal history of cancer, early menarche or late menopause, pregnancy, the first pregnancy after the age of 30, lobular cancer in situ. Lobular cancer in situ is considered benign, however, because it's encapsulated, but it does increase the risk for breast cancer. Obesity after menopause, which is oftentimes quite typical. Combination HRT, so progesterone with estrogen. BRCA, so that gene can result in either mastectomies or oophorectomies. They may choose to get their ovaries taken out. And in men, risk factors are hyperestrogen, so greater balance of estrogen to testosterone, a family history of cancer, and also radiation exposure is more significant in men. Factors that affect the prognosis of breast cancer: the size of the tumor when it's first found, whether or not lymph nodes are involved, and then what type of tumor it is, and then if they are positive for what is called HER2, it is a tumor marker, HER2. There are, we divide breast cancers into non-invasive and invasive. Non-invasive are intraductal cancer and ductal cancer in situ. Anytime it says in situ, that means it's encapsulated and it's localized and it's more amenable to treatment. Left untreated though, it can become invasive. So it is important to diagnose and take care of it. Again, lobular cancer in situ usually does not require treatment, but a lot of women on with LCIS will actually go for chemoprotection on tamoxifen. So you'll typically see women on tamoxifen in some cases. Then invasive ductal cancer. There are a couple of types. Paget's, it's not the bone Paget's, but it refers to lesions of the nipples and the areola. Typically, treatment is a mastectomy, and it actually has a good prognosis if it's confined to the nipple area. Inflammatory breast disease, breast cancer, is the most aggressive type. Typically what you see is red, warm, and orange peel-like appearance. Unfortunately, it blocks the lymph glands, but also metastasizes through those lymphs. Typically, treatment is with chemo, with radiation, with hormones, and biologic treatment. It's not as treatable as non-invasive. Clinical manifestations generally then of breast cancer: a lump, usually in the upper outer quadrant in the axillary region. It may be irregular or poorly delineated. It's not nice and round. It's non-mobile. It may be non-tender. Non-tender tend to be more malignant than tender. There may be nipple discharge or retraction. Again, as with the invasive breast cancer, it has that orange peel appearance. There may be infiltration, induration, and also dimpling of the breast. Complications: the most important complication of breast cancer is that it can recur, most often at the site where surgery was done. Also, it can be localized, it can move regionally, or it can metastasize. Diagnostics, again, include what we've already talked about for non-invasive breast disorders. Prognostic risk factors, though, again, in other words, likely to make it worse, is axillary node involvement. That is probably the greatest risk factor. And what they will do is actually lymph mapping and also sentinel lymph node dissection to identify the number of nodes that are involved. Typically what they see is if the tumor is in the synthesis phase of development, and also if a woman has that HER2 marker, there is increased risk for poor prognosis. The size of the tumor, whether or not it is estrogen or progesterone receptor negative, those are less responsive to HRTs, hormone replacement therapy, and the speed with which the cell is dividing or proliferating. Those are all poor risk factors. Care can include surgery. Typically the gold standard was a mastectomy, and it was usually a radical mastectomy with removal of the breast, the lymph nodes, the pectoralis, the muscle supporting the breast, and all of the fat and the adjacent tissue. But now there are many, many other choices. And the problem with that is that women, if we were to pick a diagnosis for women with breast cancer, is that now they have decisional conflict, because many of the decisions with regard to treatment are left up to the woman. And that is kind of scary, because if you feel like you don't know what, the pros and cons are for all of those, it can cause a lot of anxiety. And ALND or axillary lymph node dissection is the standard for invasive breast cancer, but also they can do sentinel lymph nodes. And what they do is oftentimes determined by staging using that TNM tumor size, whether or not it has gone into the nodes and whether or not it has metastasized. And again, whether or not it's in the lymph nodes is probably the most important prognostic indicator. Also, they can do breast conservation therapy, so doing like a lumpectomy or just a partial versus a radical mastectomy. Here they might just remove the tumor and then some of the normal tissue just adjacent to the tumor, and then follow that up with radiation. If it is systemic cancer, then chemotherapy is usually used before radiation. And the advantages of doing breast conservation therapy, obviously, is that it preserves the breast and the nipple. The disadvantages are that it does cost more, and if a woman has to undergo radiation, there are more side effects that then they have to deal with. A modified radical mastectomy removes the breasts and the axillary nodes, but it saves that pectoral muscle. So it doesn't have as much impact with regard to movement on the affected side. It is the best option for breast reconstruction, but follow-up has to occur for the rest of their life. Exams, the recommendation is every 6 months for the first 2 years, and then annually, also doing monthly breast self-exams. Remember that recurrence of breast cancer usually occurs at the surgical site, and yearly mammograms are also suggested. Unfortunately, after these surgeries, post-mastectomy pain syndrome can develop, and that primarily is pain to the chest and the upper arm. They can have numbness and tingling to the arm. Also, it can become quite itchy, usually related to edema. Treatment can include NSAIDs, antidepressants, actually because of the frustration associated with continuous pain. They can use topical lidocaine or EMLA cream. Also, anti-seizure drugs such as gabapentin, which affects the nerves, has been found to help post-mastectomy pain as well. Adjuvant therapy includes, again, can cause decisional problems. Again, it is based on staging. Also, they take into consideration a woman's menstrual age, if the cells, what the characteristics have, whether or not they're positive or negative estrogen receptors. Again, if there's a HER2 marker, and then what the other health issues are for the woman. So radiation therapy, they can do primary radiation, adjuvant, and palliative. Primary radiation therapy is usually done after they've excised the tumor, and then they'll do daily radiation for about 4 to 6 or 5 to 6 weeks. When they're doing external beam radiation, it can cause some skin changes, so recommendation is not to put lotion or other skin treatments over that area, and you want to watch that area for breakdown. Adjuvant therapy, radiation can be done in conjunction with other treatments, and then palliative is usually in cases of metastasis, and it's for pain relief to treat symptoms. They also can use high-dose brachytherapy, which involves internal radiation, placing radiation seeds in the body. They also can do systemic therapies such as chemotherapy. One of the benefits of breast cancer is that it is fairly responsive to chemotherapy. Doxorubicin or adriamycin is one of the more common drugs. The unfortunate thing is it can be cardiotoxic. So you need to watch for signs and symptoms of cardiovascular and or heart failure. So things like ankle edema, shortness of breath, decreased activity tolerance, dysrhythmias. Anytime you note that there is dysrhythmia or irregularity and the woman is on doxorubicin, notify the doctor. Also, if there's ankle swelling and they're on doxorubicin, that could indicate that there is toxicity with that. Hormonal treatment then usually is done with tamoxifen, and tamoxifen is used particularly with estrogen receptor positive adenocarcinomas. Remember, we said a poorer prognostic risk factor is negative estrogen receptor. So tamoxifen does treat positive receptors. Biologic therapies that can be used, probably the most common one is Herceptin or trastuzumab. It causes ventricular dysfunction, however, and also symptoms of heart failure, much like doxorubicin. So if a patient develops ankle swelling or shortness of breath on that, or arrhythmias, you would want to notify the doctor there as well. There are differences with regard to how women respond to a breast cancer diagnosis. It can be cultural influences. Nursing management, again, with regard to diagnosis, again, there are so many options that decisional conflict is a common diagnosis related to treatment options. And then one of the biggest problems post-mastectomy and surgical treatment for breast cancer is lymphedema. Some of the treatment plans then for lymphedema is doing exercises, so moving that fluid around. Also, it's very important that if they're in the hospital, you put a sign above their bed that says no blood pressures or IV puncture in the affected arm. Also, you should teach women who have lymphedema to try to protect that arm. even from the most minor injury. Reaching over a stove is probably one of the most typical injuries that women suffer, because most women are at the stove, and a minimal burn can result in significant impairment, infection, and problems associated with that. Later post-op treatment can include a compression sleeve to help move that lymph fluid and push it back to the heart. Elevate the arm above the heart, and also diuretics can be used in order to get rid of the fluid. Psychological support, obviously very important in treatment of cancer. Mammoplasty, then, very briefly, can be used to reconstruct the breast, but it also really refers to any changes that are surgical changes that are made to the breast. It can either be to enhance the size of the breast, to reduce the size, or to do surgical reconstruction. Indications for mammoplasty can include to improve self-image, regain normalcy, and also to assist in coping with breast loss related to mastectomy and cancer. Types of reconstruction can include breast implants and tissue expanders. That's probably the most common reconstruction. That involves usually weekly injections of sterile water or saline, and a lot of times they will insert a magnet so that when they go to give the injection, they can find the port. Of course, with a magnet, that would rule out that woman getting MRIs, because that could displace that port. A lot of times when women have had implants, physicians will encourage them to massage the breast. That helps to eliminate the complication of contracture, wrinkling, scarring, etc. Probably one of the most common reconstructions with cancer is the TRAM procedure. It is a musculoskeletal flap. What it does, or muscocutaneous, it takes skin from the abdomen, tunnels it up into the breast area, and it's used to then reconstruct the breast. Surgery does take about 8 hours to accomplish that, and post-TRAM recovery takes about 6 to 8 weeks, so it's a fairly long recovery. So you need to prepare women for that length of time. Also, nipples and the areola area can be reconstructed. I actually saw one reconstruction using a tattoo artist who put a tattoo of the areola, and it looked exactly like a normal areola. It actually was on that show. What's the one with the plastic surgeon guys? Oh, I can't remember. There's the two guys that, Botched. Yes, Botched. He called in a tattoo artist, and it was pretty interesting. Then breast augmentation, or enlarging the breasts, usually is done in an outpatient setting. Typically, when they have breast enlargement and augmentation, they will place drains. And the reason for that is to decrease hematoma formation. Usually those drains come out at around 2 to 3 days post-op, or they also are discontinued if there's less than 20 to 30 cc's over a 24-hour period, but generally 2 to 3 days post-op. So discharge teaching of a woman with breast augmentation should include drain care, monitoring the color of the drainage, whether or not there's an odor, and the amount, checking for bleeding, etc. Dressing changes should be sterile. You want to monitor for infection. A good support bra is also important. Usually they can resume fairly normal activity in 2 to 3 weeks, but more strenuous activity not for about a month or 4 to 6 weeks. And if a woman has undergone breast reduction or surgery, if the nipples have not been manipulated, usually a woman can continue to, or can breastfeed when they get pregnant then. So that's something to consider. Okay, let's take a break and then we'll come back and do female reproductive system and go on to male.